Well, thank you very much for inviting me, Beringer. And I'm not sure, to be the speaker who's put on the program right after lunch, I don't know whether I should be insulted because they just assume that you'll all be asleep, and so they'll put the poorest speaker right now, or I should feel good because they put me now because I'll keep you awake because I'm such a great speaker. So I'm going to choose to think it's the second rather than the first and just hope that I don't go to sleep during my talk. I was asked, this is actually the title of the talk that I was given to give you, which isn't the title that's in the program. So I'm really going to talk about why pigs cough and why that should matter to us as swine clinicians. And from my standpoint, for the last 30 years have been a veterinary diagnostic pathologist. So I've taught graduate and undergraduate courses in the veterinary school in pathology, but primarily I'm a service pathologist working in diagnostic laboratories doing cases, both gross and microscopic necropsy. But to a greater extent, at Iowa State, we have a very large laboratory with 10 pathologists, and we do about 70,000 cases a year. And in the last few years, the services that we deliver, about any test you could imagine, including next generation sequencing and varieties of other sorts of analyses, we have a web interface with our laboratory information system, our computer system, so our clients can go in and not only look at the results on their cases, they can set up the interface so that it delivers results to them in the fashion that they want. For example, they can have it sort through all the cases that are in their name or in their clinic's name and then deliver only the new results that have come in since the last time they checked the system. And now they have an app for their smartphones for our laboratory so that they can do the same thing through their smartphones, and they can punch a case number if they have a question, and then on a page on their phone they can punch my face, which gives them my email, unfortunately. And so day or night, 7 days a week, I will get emails from clients asking me questions about their cases. But what it has done is created a really interactive environment between our clients and us as we're doing cases. Each week I do anywhere from 50 to 70 cases that include all of the histopathology. I order all of the tests. I interpret all of the results and then write a report with a summary of what we consider to be the most important findings relative to the diagnostic questions that our clients have asked us, which may be varied. Not just why are the animals sick or dying, but why do we have so much weight dispersion? Why are the weaned pigs not starting on feed? All of sort of questions like that that are trying to look at underlying subclinical infections as well as other things. So with that in mind, what I'm really going to talk about today then is looking at respiratory disease, and we're really going to focus on, in the respiratory disease complex, probably the three most significant primary pathogens that I hear people from around the world say that they struggle with, that being PRRS virus, swine influenza virus, and Mycoplasma pneumoniae. And we're going to ask this question. How do these organisms cause disease? I mean, how do they actually cause pathology? And then within that, why does that pathology cause the animals to cough? And is there really a difference between the kind of coughing that we see between these different agents, such that we as swine clinicians can listen carefully, along with our understanding of the epidemiology that may be also supplied by clients, and get an understanding, in addition to the other information we're collecting, clinical signs, that'll help us arrive at a more consistent and correct initial diagnosis before we get laboratory results back. Okay, so just to begin with then, generally, why do pigs or why do we cough? And the simple answer is that we have embedded nerve endings that are in the mucosa that lines our nasal cavity, and of course if those are stimulated we sneeze, and then from the larynx down through the conducting airways to the terminal bronchi, those are all lined by the same kind of epithelium that is the surface of the mucosa. That's pseudostratified, columnar, ciliated epithelium, for all of you that remember that from histology in veterinary school. All right, and embedded within that epithelial layer are nerve endings, and when those nerve endings are sufficiently stimulated, that will end up causing an animal to try and usually to clear whatever obstruction or problem is in that conducting airway in that location, and the result is a cough. So with that in mind, are there really differences in coughing? And we can ask the question then, well, what are the different kinds of lesions or pathologic changes in that mucosa that could then end up causing those nerve endings to be stimulated that will then end up resulting in a cough? The first one is just infection of those cells and destruction of those cells. And in that case, it would typically be a virus. And the virus that we would most often think about would be influenza virus. So if we're going to just look at that category of viruses, in this case, they would be epitheliotropic viruses, or viruses that have a tropism for epithelial cells that bind and enter them and replicate in them. And then in this case, they would be cytopathic, so they would kill the cells. And influenza is a primary one that we would look at. We also, in the States, do see on some occasion porcine parainfluenza type 1 virus as a milder form of that disease in suckling and early wean pigs. And in that case, you just cause necrosis of the epithelium, and that stimulates the nerve endings, obviously, if you have a necrosis all around the nerve endings. Then another kind of category would be overproduction or buildup of a substance or exudate in the airway. And just think of yourself, if you're drinking fluid and you end up having some fluid run down your larynx into your trachea, what immediately happens to you? You know, that's just a little fluid trickling over the surface of those mucosal epithelial cells, and it will immediately initiate a really strong fit of coughing with you trying to clear that. So when we think about substances that are going to be in the airway that would stimulate that, one is a substance that's secreted by the mucosa. It's just secreted in excess, or it builds up because it's not being cleared, and that would be mucus. So we'll see mucus building up in airways in the case of Mycoplasma pneumoniae, or we can have other irritants that will cause excess mucus to build up. Smoke, so those people who smoke as a habit, that irritation will cause more mucus in the airways. Smoke inhalation and fires will do that. Excessive dusty conditions in buildings will cause some excess mucus in airways. And then the other kinds of fluids that we can have build up, one is just edema fluid that will come into the airways from deep in the lung in cases where you have acute inflammation. We're going to talk about that as the primary stimulus for coughing with PRRS virus in most cases. And then the other is later in infection when you have secondary bacteria that cause buildup of pus in the lungs or purulent exudate. Then you can have some of that material being cleared up through the airways, and that the pieces of that, as they're cleared, will stimulate some coughing too. Hence the reason we see coughing as we get severe respiratory disease complex and quite a bit of secondary bacterial bronchopneumonia in animals. So I'm going to have this same chart at the end of the talk, and I'm not going to go through all of it now, but I made the chart to kind of ask the question, is all coughing the same? And I would argue it really is not. And hopefully, by the end of this talk, you're going to be able to go through this chart and understand why I put each piece where I did in the chart, and use this chart to kind of help you use that as a piece of an additional piece of information when you're evaluating respiratory disease in swine. So let's start by talking about PRRS virus. We've already heard a lot about PRRS today, some about the virulence factors or the way in which PRRS causes disease. So I'm going to hit the highlights of that. I'm not going to go into great detail. One of the things I was asked to specifically talk about in this talk was just some of the things. First of all, the definition of what an atypically virulent strain of PRRS is, or a high-path strain of PRRS, and how high-path strains differ from lower virulent strains of PRRS in the way that they cause disease. Okay, so we'll talk about that in the midst of this talk. Let's just start out with this this overall slide that kind of summarizes the major ways in which PRRS virus causes disease. First of all, as we've already heard, PRRS virus replicates exclusively in a subset of macrophages that display the receptor that is absolutely required, which is CD163. And the macrophages typically that we're talking about are those that are activated, or they're differentiated enough to be actively involved in phagocytosis and killing of various foreign substances in the body. And the CD163 ones, the primary place that we're talking about in postnatal infection with PRRS are in the lung, in intraalveolar macrophages and intravascular macrophages. So they're the ones that reside within alveolar septa and then within alveoli themselves, and then the ones that reside inside the alveolar capillaries and venules that are in the lung. They actually attach to the lining of those vessels. Okay, and in that case, and then the other places that we see them replicated, as we've already said, replicating in lymphoid tissues throughout the body in postnatally infected animals. And then, so we've already talked about, which I'm not going to talk much about today, in fetuses, in the lymphoid tissues of fetuses. And then I'm going to also mention that in some of the atypical strains of PRRS, the ones that are more virulent, we're seeing on occasion PRRS strains causing clinical nervous disease with large amounts of virus and lesions in the brains of these animals. And I, for one, have been really cynical about that, thinking that we were probably missing another unknown agent in the brains. And I can talk just a little bit about what we found and why we think it is PRRS virus. And parenthetically, that is one of the clinical signs that the Chinese reported when they first started breaking with their high-path strains of PRRS, where that some of these herds showed a significant amount of nervous disease when the animals were infected with those strains. When I read the papers, I thought, well, they probably just have something else in the herds and are missing it. And I did that because dogmatically we weren't seeing it at the time, so I didn't believe they were seeing it. You know how dogma can be, right? It can blind you. And then we started seeing it, and I still didn't believe it, but I kind of believe it now, and I'll tell you why. All right, so then once they infect the macrophages, they do several things. Okay, first, talking about suppressing the immune response. They suppress the immune response in a lot of different ways, but just broadly. They suppress the neutralizing antibody response. So we have this unusual situation with PRRS virus that we're all aware of, that we have a virus that you can handily find in the serum of postnatally infected animals, the younger ones, for a month. Can you think of any other virus that persistently infects animals in such a way that you can just draw a serum and find the virus in the serum for a month after they've been infected, as we can with PRRS virus? But one of the reasons that happens is because PRRS suppresses the neutralizing antibody response. And when they do seroconvert and produce neutralizing antibodies, that's the beginning of the end of the viremia that we see, and the majority of the shedding diminishes at that time. And then we end up with a persistent infection in lymphoid tissues that is finally cleared by a cell-mediated immune response that's also delayed. So we can detect PRRS virus in lymphoid tissues at a low level for up to sometimes 5 months in some animals, although that's the far end of the spectrum. In most animals, it would be less time than that. Then the second thing that they do is, if we think about the cell that they're replicating in the macrophage, it was already stated this morning that from the standpoint of the immune system, the macrophage would be kind of like the commanding general of the army, if you will, because the macrophage is that cell that engulfs organisms, breaks the organisms down into component parts, and then displays parts on the surface as on antigen, and presents the antigen to other lymphoid cells for them to respond to. But at the same time that it's doing that, it secretes various molecules that are secreted into the milieu around it that directs a variety of other parts of the immune system as well as the inflammatory response. So as you can imagine, if you're infecting those very cells with a virus, those cells don't operate normally. They secrete abnormal complements of immune and inflammatory cytokines, some more than they should, some less than they should, which then results in an altered immune response and it results in an augmented inflammatory response. Now, in a lot of tissues, that's not that big of a deal, but we're going to see when we're specifically talking about strains of PRRS virus that infect the lung, it's a really big deal because it's a systemic disease, so the entire lung is involved. And if you have inflammation in an entire lung, if we think back to our general pathology in veterinary school, do you remember that old Latinized sequence of terms that we had to learn that went rubor, tumor, calor, dolor? Does everybody remember that? You'd like to forget, I know, but we all had to learn it, which is really the sequence of events that we go through in an inflammatory process, and those events are generated by the secreted cytokines by macrophages and other cells. The first part of that sequence is rubor, which is increased blood flow into the locale, where the cytokines are being secreted. Okay? And as I said, in the lung, unfortunately, the locale is the entire lung because it's a systemic disease. And then the next stage, which is really devastating, is tumor, which is increased vascular permeability, allowing fluid from the bloodstream now to seep through the capillaries. And in this case, we're talking about alveolar capillaries in the entire lung. So we end up with a movement of fluid from the alveolar capillaries into the alveoli. In other words, we end up, depending upon how virulent the strain of PRRS is, we end up with some degree of generalized pulmonary edema. Okay, and we're going to talk about that a little bit. It's the basis of coughing. It's also the basis of a lot of the mortality in the first few days of highly virulent PRRS outbreaks for respiratory disease. And it's the one thing that we can treat pretty readily if you're allowed to use anti-inflammatories through water. Are you all able to do that legally? Still can? We can too. All right. Which you know we can if you can. All right. And then the last thing is a reduction in its ability to phagocytize and kill bacteria. And this is one of the reasons then when we have PRRS virus infection, we have a decrease in the number of macrophages, a precipitous decrease in the number of macrophages that occur. As the viral load goes up, since you can imagine the virus load is coming up at the expense of killing the macrophages that it's replicating in, you have a concurrent inverse reduction in the number of macrophages over time. And as those macrophages reduce, since they're the first line of defense against commensal bacterial invasion causing septicemias, we end up with an increased tendency towards septicemia during acute PRRS, where we see typically strep suis, septicemias, and Glasser's disease as a consequence of acute PRRS. And in our country, with type 2 strains of PRRS, we see that all the time. And then the other thing that we see is an increased ability of commensal or opportunistic upper respiratory bacteria to cause bacterial bronchopneumonia. They aren't very good pathogens. They need help to do it. And in this case, with an absence of alveolar macrophages to help clear those bacteria when they're inhaled, they'll end up settling in the lungs and forming that. All right, so just generally, I think we all know you in Europe here have genotype 1 or type 1 of PRRS virus, and in the U.S. we have both types, but most of what we experience is type 2. And the type 2 strains that we have vary a lot in virulence, from very, very low virulence to increasingly atypically high virulence with some strains that we see on occasion. These two types of PRRS virus differ by 30 to 40% in terms of their nucleotide composition, so they're quite different. And then within them, they'll differ up to 20%, giving us the kind of variability that we have in these viruses. So now the question is, we've heard many times that PRRS viruses are RNA viruses, so they mutate rapidly, and we all live experiencing that with strains that escape vaccination and cause problems in our herds. What then makes a strain one that we'll call a high virulence strain or an atypical strain? The Chinese coined the term high pathogenicity strain. I think it would be more appropriately called high virulence. Generally, it's really simple, I think, to define it. We become used to a constellation of clinical symptomatology with the majority of strains that we experience in the locale that we live. In our case, our laboratory does work for all of the United States, so the locale in which I live is the United States and Mexico, because that's where we get our cases. And when I start seeing reports of disease that's different in its type of presentation, or simply just more severe, more of the same, but far more severe than we've seen in the past, it rises to the level of thinking it's atypical. And then to prove that, it really needs to be put back into a challenge model and compared against previous known strains so that you can actually demonstrate in an objective, controlled inoculation model that it indeed is different than the other strain, and that you're not measuring some extraneous factor that wasn't the PRRS virus strain itself. So both of those things occur. We have strains, for example, that in the recent years that I'm seeing lesions in pigs that are far, far more severe in the lungs than we have seen in the past. And I'll talk a little bit more about that when I talk about one of the ways in which PRRS causes lesions. It's called bystander apoptosis, and I'll talk about that here in a minute. Another one, as I said, we've recently seen in some herds, the veterinarian will call and say, look, I've already confirmed that we're going through acute PRRS, but we've got nervous disease, and 20% of these pigs are showing mentation changes, and they're going down, and they're paddling, and they're dying, and we've got two things going here. We know we have PRRS, but we thought it was strep suis meningitis, but it isn't. We've sent several brains in, and they don't have meningitis. You haven't been finding strep suis septicemia. What is this? And microscopically, they have lesions of very severe viral encephalitis, and we've done a lot of different sorts of tests on those brains and have been able to confirm very high levels of PRRS virus in the brains, not just by PCR, but using in situ hybridization and immunohistochemistry, where we can demonstrate the PRRS virus within the lesions, within the very things that we're looking at this point. And I've been very surprised by that. I was a cynic in regard to PRRS virus being a nervous disease prior to that. It's not often that we see it, but I'd have to say I've been doing this for 30 years, and I never saw it until the last 5 years, and I've probably seen, in the last 2 years I've seen 6 cases where they were losing, and I'm talking about large herds, losing in the hundreds of animals over a period of time with an acute PRRS outbreak with these strains. All right, so we already know that along with all this genetic diversity comes a lot of antigenic diversity, and it's the reason that a single strain in a vaccine won't adequately protect from all strains of PRRS virus. I think we're all well aware of that. And we increasingly, for our clients, because most of the herds we deal with are very, very large herds in systems that cross several states, and the average size wean to finish barn that we're dealing with is between 2,000 and 5,000 pigs. So in these size of systems, they're constantly asking the question, are we dealing with one or more strains of PRRS virus simultaneously affecting these populations or flows of animals? And how does this strain compare to the last one that we had? Is it an internal strain, or do we have evidence of a biosecurity break that we need to look at our company and fix? Was it introduced laterally? So they keep dendrograms of all of the sequences on these strains. The thing you need to know in sequencing, if you haven't done that much of it, is that all it's really good for at this point is comparing strains to ask, are the strains the same strain or are they significantly different? It doesn't predict protection. It doesn't predict cross-protection. It doesn't predict virulence. It only is a fingerprint to tell you its relatedness to another strain at this point. Maybe someday we'll be able to do those other things, but today we can't. Okay? And I've already talked about cell tropism. Maybe part of the picture on the virulence of PRRS has to do with this cell tropism, but the jury is still a bit out here in that some in vitro work with PRRS virus has demonstrated that not only CD163 being the required receptor for PRRS virus in cells, that when you do in vitro work with cell monolayers and you introduce these various receptors, if you introduce also a second receptor called CD169, which is sialoadhesin, Cyanoadhesin seems to accumulate more PRRS virus toward these cells so that the cells more readily bind it to their CD163 and internalize it and become infected. In those cell monolayer systems, they demonstrated that the doubly positive cells, that phenotype of cell, would tend to produce 10 to 100 times more virus than just CD163 expressing cells alone. And it may be that part of the picture with these more highly virulent strains of PRRS virus is that those strains have developed the ability to reach a broader phenotype, if you will, of macrophages that don't fit just the CD163 expressor only, but that they're multiple expressors of receptors on the cell types. And there's some data that would support that, and then there's some data recently in reproductive work that might argue against that. So I think the jury is still out with that one. Okay, and I've already kind of talked about this in terms of its impact on replication in macrophages. But let's really kind of concentrate on, as we look at this slide, as PRRS replicates in these macrophages, kind of answering the question of why do we have respiratory disease rather than just replication of the virus in the lung? I mean, theoretically, if you have it replicated in macrophages in the lung and the macrophages die, they could just be carried up the mucociliary apparatus and disposed of. And if it were only that happening, we really wouldn't have pneumonia, which is really inflammation of the lung, right? You just clear it like you would any other particulate antigen in the lung. But that's not what happens because we have this perturbation of secretion of cytokines, and we have it generate inflammation. So I've already kind of described the way in which we get inflammation and we get pulmonary edema in the lung. And in the acute stage of disease, we get variable amounts of pulmonary edema. One of the primary differences between type 1, one of the reasons that many of you don't see respiratory disease as being a severe consequence of PRRS, is that a true statement? Do you see PRRS being a really significant respiratory disease in your weaned pigs? Absolutely. Okay. I was going to say, in the U.S., you absolutely do because they die. Yeah. And, I mean, they die because of strep septicemia and Glasser's disease and some other things, but sometimes they just die from only PRRS. I mean, it's a very severe disease. And I'll show you some of the pictures of our really virulent strains in those cases. Other strains, they don't die, and they really don't even get that severe pulmonary edema with it. So there's a lot of difference in the strain. But when we talk about this whole coughing thing with PRRS, you know, honestly, if I think about PRRS virus and clinical signs that I'm seeing, even in weaned pigs, coughing isn't the first thing that comes to mind for me. Is it for you? Yes? Some of you? Yeah, you know, I think of these pigs that look like they're a little hypoxic, and they'll stand and they're a little bit lethargic and slow. They'll have their elbows out just a little bit, and they'll kind of be abdominal breathing, like they've got a little pulmonary edema. And then those same pigs, if you move them around, then they'll get a little of that fluid in their airways, and you get this kind of high-pitched, short, productive cough. You know what I mean? There's a little fluid in it. They kind of go, and you get that kind of push and sound like they're trying to clear the fluid. But what you don't tend to get are these long periods. They don't sit there and do that and go and just keep coughing. And I think the reason is because they have fluid, but more than anything, they're suffering from hypoxia. And so they'll end up having kind of a shorter tidal volume. If you watch them, they're sitting there kind of puffing. And then they give you those coughs. Sometimes they'll be a little hyperemic because of these inflammatory cytokines that you're seeing. All right? And then the other thing that we see is this issue of bystander apoptosis with PRRS virus. So what that means is that, and I'm going to show you a picture here, a little bit of a histologic picture of a fairly virulent strain of PRRS virus that's caught just at the right time, that you see alveoli are completely full of necrotic macrophages. In fact, here, see how far I've got to go. There it is. So it's even hard to tell this is lung, except for the fact that you see this airway over here. But these darker blue stripes are the alveolar septa. This is where the airspace should be, and those are all necrotic alveolar macrophages. Now, the funny part is, if I take immunohistochemistry and I stain that so that you can see which of those cells are actually infected with virus, only a small portion of those cells are actually infected with virus. And you've got all these cells that are dead. And the reason is because the cells that are infected with virus are also secreting cytokines called apoptins. And those cytokines go over and they tell the other macrophage to commit suicide, is essentially what they do. So all of our cells have within them a pathway to kill themselves, or so that the body, through other cells, as we heard earlier, CD8 lymphocytes go over and actually stimulate those receptors on cells and tell them to kill themselves. So if we have abnormal cells like cancer cells, most of those get stopped at the onset because they're recognized as abnormal, or they recognize within themselves abnormality and they kill themselves. But in this case, we have an abnormal production of these cytokines that are telling a variety of different cell types to kill themselves. And we've discovered in recent years that it's this bystander apoptosis function that is much more severe in the highly virulent strains, but it's really the basis of a lot of the pathology that we see in both fetal death as well as postnatal infection. So I'm going to just talk about the lung now. We have this necrosis of macrophages, but the other thing we have that affects the clinical signs that we see with PRRS virus is it'll actually cause apoptosis of the type 1 pneumocytes that line alveolar septa. And this is really where it varies between the virulence of the strains. Typically, when we see lungs of pigs that have PRRS virus, when I look at them, type 2 pneumocyte hyperplasia is what we see when type 1 pneumocytes have died, and the new immature pneumocytes that replace them, instead of being nice, flat, squamous cells like they're supposed to be, are kind of cuboidal shaped. And you can imagine if you, instead of having nice, flat cells that oxygen can easily diffuse through to get to your alveolar capillaries, if you replace them with little square cells that oxygen doesn't diffuse through very well at all, you end up with a lung that just doesn't work. Okay? And those will remodel back to being flat pneumocytes pretty quickly if the pig lives through the period that it has type 2 pneumocyte hyperplasia. And this is one of the lesions that more recently in some of these really virulent strains, when I see it under a microscope, there really aren't that many other causes of significant type 2 pneumocyte hyperplasia in weaned pigs. So when we see that combined with a history that suggests PRRS, I already pretty much have a good idea that I was dealing with PRRS in those lungs. But you can imagine if we take this little pig now that's had pulmonary edema, and he's already got a short tidal volume and he's not very well oxygenating, and then he loses type 1 pneumocytes and further thickens his alveolar septa. Now we get the blue noses and we get animals dying, and I got to go really fast because I'm almost out of time. Okay. I can do this. Okay. And I've already said all of this stuff, so I'm in good shape here. All right. What's the difference between the strains and virulence with PRRS virus? I've already basically described most of these things, okay? They produce much higher virus, and we think that's probably based somewhat on a broader cell tropism. They do increased killing of infected macrophages and significantly increased bystander apoptosis, so they cause more severe lesions. And they also secrete much higher levels of inflammatory cytokines, so much so that researchers have had a hypothesis that one of the reasons the mortality will be so high in some of these outbreaks is that they're actually dying from the cytokine storm itself, where the animal goes into shock because of just perturbation of inflammation in the body. Okay, so they actually just call that a cytokine storm form of shock, and that term was coined in human medicine. Okay, so just in summary of kind of our whole pathogenesis for coughing here, we end up with these intravascular macrophages, and then the intraalveolar septor macrophages are thin alveolar pneumocytes. And when we have PRRS infection, we secrete cytokines. We end up with increased vascular permeability and movement of fluid out into the alveolus that then generates the coughing. Okay, The picture on the left is normal lung, showing you what an alveolus should look like at high magnification. And on the right, you can see that how thick those alveoli are, and you can all picture those little kind of round cells all along. Those are type 2 pneumocytes. I think you can see what a difference there is in oxygen diffusion in that lung. Okay, this is just a picture of Leylestad virus as the type virus of type 1 on the left-hand side, an intermediate virulence virus, and then a high virulence virus on the right. And this, I should say, this study was done, one of the 9s was dropped from the label at top by Dr. Halberd in 1995. It's not as if we've not had these higher virulent strains for a long time. Okay, this is just a summary of everything I've just said in terms of coughing. The only thing I'd point out, when we're looking at coughing, it's not just the character of the cough itself, but it's also how rapidly that virus is transmitted in the population. And I think we tend to think of all respiratory viruses as being transmitted equally fast, that we should think that they should infect all the pigs in a room or in a barn in a few days. But that really isn't the case. It may be the case with influenza that's transmitted very rapidly, but PRRS, where there isn't as much coughing, it's highly infectious, but it isn't as highly transmissible as influenza viruses, for example. And in these large barns, I can just give you a common thing that we have happen when we have 1,000 head or larger barns. I'll get an email from a practitioner that'll go something like, we've had PRRS breaking in this barn for 2 weeks, but we still are having death loss, we're still having new cases. Something else must be happening here. And so they send in new cases, and they're all acute PRRS again. And it's just the idea that it should be over by now. But they're actually still just having new cases go through this barn. And they're just not thinking correctly about the disease. And part of that is just the scale of the barns we're looking at anymore. We're not looking at 400 head barns or 500 head barns. When you get up to 2,000 head barns, just by nature, it's a lot more space to cover for all of the animals become infected. So influenza virus, I'm going to skip kind of some of the introductory stuff, but it's a really pretty easy story. Influenza virus is not a systemic virus in mammals. It just infects the respiratory tract, and in the respiratory tract, it primarily infects those cells that line the conducting airways and the upper respiratory tract. So it actually infects the pseudostratified columnar ciliated epithelial cells, and to a lesser extent, it will infect the type 1 pneumocytes. So what we come to associate with influenza is kind of this characteristic cough, and it's because it infects, and you can see in this picture on the right-hand side, this is actually an airway that should have pseudostratified columnar epithelium, and instead it has almost squamous epithelium on it. That's the epithelium as it tries to cover what was missing when it was completely eroded from influenza. The lesions that we look at under a microscope are very characteristic. Not anything else really looks quite like influenza. And the explanation for coughing is really straightforward in these cases. It's because you've actually exposed the nerve endings, and you have almost a continuous stimulation for coughing in these animals. Now what will happen is after a while the nerve endings will kind of settle down a little bit, but when a pig coughs the first time, just the act of coughing, because it's such a robust cough, they push out air so hard, it actually irritates the nerve endings, just the act of coughing. So that cough stimulates another cough and another cough. So we tend to get pigs with influenza having fits of coughing or paroxysmal coughing. And the cough in this case is this, people have described it as the sound of a goose honking, because it's this really a pushed kind of strong cough when you get those. So they kind of go, you know, if you've heard those coughs, there's nothing else quite like it, and that's why clients, when they're used to hearing influenza, they'll be able to call you and tell you, yeah, I've got flu going through my hogs. You know, I've heard it before. I know this is flu because flu sounds like flu, right? And it's pretty straightforward in those cases. Sometimes, at least I have practitioners that somehow think that flu kind of miraculously appears in their grow-finish barns because they're not used to recognizing it when it goes through their suckling pigs at a much lower level. So in that case, you end up usually with just a few pigs and a few litters that are carrying influenza. and they have very limited segmental lesions in their airways. And those little guys don't have nearly as harsh a cough. So you get kind of the same character of cough, and I don't have a high enough voice to do it, but it's this really high-pitched little squeaky kind of Have you heard them? Suckling pigs, and you'll hear just a few of them, and they're really easily just ignored because they're not going to be a high prevalence. But then when you mix them in nurseries, those are the ones shedding, so that the ones in the nursery that have decayed maternal antibody or not much, they'll start perpetuating it, and then you get an outbreak in your nurseries. So that's really the story of influenza and coughing, and I'm really rolling through this now. Last point I'd make about influenza is that because these lesions tend to affect airways, they infect them in segments. You know, they'll start in a few locations, and as the virus spreads, you'll end up with kind of a tubular segment of an airway involved, but not the whole length of every airway is involved. So what you end up with for a lesion on a lung, if you look at the top and the bottom picture, is where the segments are involved, as that services lobules distal to it, those lobules will end up having pneumonia in them, and you'll end up with purple discoloration of those lobules, but they'll be right adjacent to lobules that are uninfected because the segments of airways that service those lobules are not affected. And it'll tend to concentrate around the hilus and in the cranioventral lung. It's where you'll see those lesions because of the way turbulence and airflow is. It'll carry large droplets to the cranioventral lung first when the pigs breathe them in. So I say this because if you look at the lung on the top, a lot of our practitioners will look at that lung and go, oh, cranioventral, purple, somewhat firm lung must be mycoplasma, right? But that's not mycoplasma. That's subacute influenza. And if you cut across that cranioventral lung and you squeeze it and look at what comes out, it's just going to be foam. There's not pus in these airways, and there's not mucus in the airways like we would see with mycoplasma. There's just foam because what you're actually looking at is a concentration of lesion and then dependent edema in the cranioventral lung that's giving you that pattern, but that's actually influenza, all right? And this is just a summary of everything I've just said for your notes. Now let's talk about mycoplasma. Mycoplasma has a complicated and kind of interesting pathogenesis that I don't have time to talk about, so I'm just going to focus on the part of it that has to do with coughing. Mycoplasma colonizes airways for extremely long periods of time because it has the ability to shift the antigenic profiles on its surface. So it just continues to fool the immune system and change its face. So pigs once infected with mycoplasma will be infected for over 200 days. Once infected, they're going to be infected all the way to market, typically. Okay? So the key to actually, and the other thing to realize is infection with mycoplasma is not equal to disease with mycoplasma. Okay? You actually, it's a combination of dose and time that results in actual mycoplasmal pneumonia. And then the pneumonia that's really costly is when it's secondarily infected with additional bacteria, that combined infection known as enzootic pneumonia. Okay? And the primary underlying mechanism that I really want to highlight here is that when those mycoplasma colonize the airways, they'll begin by colonizing in a few small patches. And then over time, that colonization will spread to include more of the airways. And just like I explained with influenza, the airways that are most likely to be colonized are the ones in the right and left cranial lung lobe and the accessory lobe because of the way that the droplets end up driving into the lung when the pig inhales it. When they colonize the cilia, then the cilia, after long-term colonization, are slowly damaged until they're severely blunted from colonization. So the mucociliary apparatus that's supposed to be carrying the mucus out along with all the particles out of the lung, it no longer gets carried out very efficiently. And also, because of colonization, the part of the way the body tries to clear the infection is secrete more mucus. So you have not just you have an accumulation of mucus from oversecretion and from lack of removal, and we end up with these clots of mucus in the airways. So now, imagine, at least when I go into barns, if you go in the morning when pigs have been kind of quiescent during the night, and a lot of people, when we go into barns, we bang on feeders or something to get the pigs up so you can see them move around. They've been laying and had a little bit of this mucus pooling in their airways if they have mycoplasmosis. When you get them up, that mucus starts to move and it simulates coughing. Okay? So now these guys, they've got just pieces of mucus in their airways. They don't have a lot of fluid, right? So you get kind of this expiratory, dry, sometimes it's a moist cough, but usually it's more dry, and they do it more when you kick them up and get them moving, and then once they're moving, it kind of settles down again. They kind of go like this. They do this. You know, if you bang them up, you hear a whole bunch of that in the barn, and then it slowly diminishes when they kind of settle back down in the barn. Okay? Think about it like a smoker that gets up in the morning. They've been laying all night. They had irritated airways. Mucus builds up. They get up in the morning and they have a coughing fit, kind of do this, and spit the mucus out, and then they're good to go for the day. They don't run around and cough all day long, right? They're just clearing the excess mucus from the airways from the ciliary blunting. That's exactly, it actually is kind of like a smoker's cough. It's the same genesis as what we're dealing with mycoplasma. So last thing I'll say here, and then I'll be done, before they put a great big hook on my neck and drag me off. Okay, so looking at the lesions, you know, one of the real dilemmas we have with mycoplasmosis is trying to assess whether we actually have a problem with mycoplasmosis, but even more difficult is to assess how much of a problem we have. And if we're trying to use a combination of antibiotic therapies and or various vaccine strategies, it's asking a question of what's working the best, or is it working at all, especially if we have multifactorial respiratory disease, right? And it's a challenge. We don't do very many slaughter checks anymore in the U.S. because our lines are running so fast in our slaughter plants. Carcasses go by every 1 second. And there's just no way to palpate or collect or even map lungs fast enough under those circumstances to do them. But even so, they have limitations. And let's just look at the lesions first. Kind of that top picture is a classic uncomplicated mycoplasma lung that's taken from an experimentally inoculated lung, showing you the classic plum coloration of these lungs. They look, I mean, that does look a fair amount like that influenza lung I showed you, right? But if you feel that lung and then you cut across it and you squeeze and look at what comes out of the airway, that's where this other picture comes in. So in this picture, there's some white blood cells in this too, so it's mucus plus some pus. But notice how it strings. You can string that up and it stays in a string. That's because of the mucus that's in it. So if you cut across this, and now if it kind of walks like a duck and quacks like a duck, in this case, they cough like mycoplasma, and you do some posting and you see this much mucus in the airways, this gives you another index of suspicion that you actually have clinically significant mycoplasma going on as part of your respiratory disease outbreak. And I would also tell you, we do a lot of histology on these lungs. There's nothing that's particularly unique about mycoplasmosis microscopically. I can give you a good idea that's what you're dealing with, but I cannot confirm it based on lesions alone. Okay, that's kind of what the lesions look like microscopically, which I won't go into. And that's a summary of the mycoplasma. And that's the chart. And I'm going to end right here. So hopefully when you look at this chart, it makes more sense to you. Oh, last thing I didn't mention of mycoplasma. Mycoplasma is very slowly transmitted compared to the viruses. So believe it or not, if we took one pig, put it in a pen of 30 pigs, put one cedar pig that was infected with mycoplasma in that pen, if we tested every other pig in that pen for an entire month, guess how many by the end of that month would be infected with mycoplasma? 1 or 2. That's it, in a month. So with mycoplasma, one of the key factors is how many of the animals are actually becoming infected at a very young age, so that you have this multiplicative effect over the time that they're in a finisher, so that you actually build up a sufficient dose to be causing disease in the finisher. Attacking mycoplasma younger is the key to disease control. And with that, I'll end. Thank you very much.